Almost one third of our population is hypertensive. And it is almost equal rural as well as urban, both almost 30%. And in last 50 years or so, with the way the cities are changing, the rural is relatively protected, but the urban is showing a huge increase, very steep increase. And I think this is a very important slide. And the thing is that the rule is of one third. One third of the people are hypertensive in the society above the age of 40. And importantly, people who are hypertensive, only one third know about it. So 2/3 population of hypertension do not know about it. And people who know who have hypertension, only 1/3 people take treatment. And of the 1/3 people who take treatment, out of that, only 1/3 are well controlled. Abhi bolo kya hoega? So that is why people like us, cardiologists, survive in this town. But it should change, and people must take treatment. This is a history of this thing, and very interesting. I think the first time BP was measured by the innovator by putting a cannula in the carotid artery, and then he went on connecting, and it went really high. And I think that is how we knew that the arteries have some pressure. And then the various things came up. And very important, this Kaplan is one of the great persons in hypertension. And the problem is we doctors, all of us, which includes me, that we don't know really how to take blood pressure very correctly. And unless it is taken correctly, you will not have a proper management of hypertension. So there are very few guidelines in the Indian scenario. Most physicians will know this, but basically you are seeing somebody for the first time, you take his 3 blood pressures. Don't take only one pressure and start. He should not be smoking or taking tea or coffee about 30 minutes prior. And with our busy OPDs, the patient rushes in and then you start taking his blood pressure, it will be definitely very high. So you must allow him to cool down for at least 5 minutes. These are all recommendations by the Indian Society of Cardiology. It should not be in a standing position. You should take either a sitting or a supine pressure. And you cannot have it should be at this level. So when the patient is sitting, the arm should be like that. You cannot take below the heart level. When you are taking first time, take both the arm pressures. Now if you don't, this is a slide which indicates, I will not go too much in detail, but if you don't follow this, if you don't allow adequate rest, patient is not sitting with a proper back support, and I think this cuff, you cannot tie very high. It should be a proper size adult cuff. It should be just about half centimeter above the elbow. Then many times I think when the nurses connect, we have to know that the bladder which is there, it should be covering the artery. It cannot be the bladder is outside. So these are all simple things, but all these simple things should be correctly done. This ABPM is a ambulatory blood pressure monitor. This is a new now method of this thing. Now all this I will tell you why this automated blood pressure monitor, just like it is a Holter. So every you connect it, there is a computer small connected, and every predetermined half an hour level it will go on taking blood pressure, and at the 24 hours range you connect to the computer, and then you will get the entire 24 hours data. Now this, in fact, in my family, my brother's son, who is just 35, I did this. Very few times you really have to do this. But he says, माझ्या घरी आहे blood pressure instrument, and I find it okay. For me, when I go to the, he is in Pune, and when I go to the doctor, he tells me it is 170 and this. And I developed tachycardia and this. So we investigated all for a few chromocytoma, others. It was not there. So finally he decided to do this test. And I found that it is only when he is anxious. So this type of blood pressure, which is called as a white coat hypertension. So whenever they see a doctor, their BP shoots up. And normally the blood pressure should come down in the evening. Now if it doesn't come down in the evening, that is called, the word which is there in red is a non-dipper. So the BP doesn't drop, and those are the ones where it should be done. So these are, when you are doubtful whether you should treat or not, this white coat hypertension, sometimes what happens, you only systolic is high, 180 by 80. And that is also fluctuating, and mainly resistant hypertension. These are some of the situations you should do this. The normal range as ESH is European Society, and optimal and normal should be about 130, 135. Anything should be below 140. The problem of ABBP is mainly, it is very cumbersome. Every half an hour it will increase. Suppose at night it is this thing, you will not be able to sleep. So it is little cumbersome. Only when it is necessary it should be done. A lot of controversies on this. JNC is a Joint National Commission, US, 8, that is very recently published. And then ESH is a European Society, and third is a American Society and International Society of Hypertension. So these are the main bodies which have been advocating what should be the pressure. But nowadays, by and large, the value at which the blood pressure should be diagnosed is above 140 by 90. Only when they should start the treatment. And that is if the pressure is, if the age is below 60 years. If someone is above the 60 years and in this thing is above the 80 years, then the range is 150 by 90. So 140 by 90 is a pressure which one should remember. If that is there, higher than that, he should start the treatment. There is a lot of controversy. See, previously in our younger college days, we used to use beta blockers rampantly. Hypertension means beta blocker. Abhi wo baad mein I will show you some studies by which it is now known that the beta blockers have taken a back stage. Beta blockers are used for, it's a fantastic drug, but it is meant for only some other disease, like especially associated coronary artery disease. One more thing in beta blocker is that they have taken a backstage, they have gone into the bracket, only when it is truly indicated it should be used. And one more thing is that the newer beta blockers have come, especially nebivolol, which in this JNC 9, maybe those will be included as a frontline drugs. Then the question is whether, when you should use two drugs at one time, as simultaneously starting, is the recommended thing is if it is above 160 by 100. These are the very simple and very nicely done chart by the Indian Society and the Indian Hypertension Guidelines. So they are basically 55 years, below 55, above 50. So in below 55, the group which is available to use A plus B. A is either ACE inhibitors or ARBs. ARB means all telmisartan, losartan and others. In that you will see that B is into bracket. So the into bracket, it should be only if at all you going to use. The Indians indicates that only nebivolol should be tried. The other atenolol, see, it is very common, and I think all this I keep on telling practitioners also, that use of atenolol should not be done for treatment of hypertension. The better drugs are losartan, telmisartan on this side, and on that side, if above the age of 50, you must start only C or D. Mainly calcium channel blockers, which amlodipine is the one commonly used, and diuretic. Now if you want to combine, then you can combine A plus C plus D. D is a diuretic, and nowadays a chlorthalidone is a diuretic of choice which has been used. the Cadillac company has a polypill, and I think although I am not a great proponent of polypill, because when you take a polypill, all the dosages are fixed. If you want to take up one dose, that is not possible. But for our Indian population, rural population, if they are not able to take, the compliance definitely improves when you take a polypill. In this beta blocker trial, there are two trials. I will not bore you too much about that research. One is a live, where the losartan was proved clearly superior to atenolol. And in that Ascot trial, the amlodipine was definitely superior to the atenolol based combination. So basically, obviously, these are the main trials by which the use of beta blockers went down. And this has been accepted, and in fact, as far as JNC is concerned, the beta blocker should have been removed from the first line use. I told you just now about the third generation vasodilating beta blockers. So probably these will get included in the JNC 9 if they prove that by giving, see, the thing is, it's not, the aim is not to reduce only blood pressure, but the aim is when you give for reduction of the blood pressure, it should also improve the mortality figures, the morbidity figures, the coronary events, the stroke events. So all these should come down. So to prove that, it will take many years before any new drug can be introduced for this. This is a systolic. This basically is what should be the blood pressure optimal level. Can you take it below 120, or can you take it keep it below 140? The current recommendation is you keep it below 140. But at the same time, if you take it below 120, then what happens is they studied in this particular trial, and I will come to the conclusion, is that what happens is that there is a slight beneficial effect, but it is negated by development of hypotension, and the renal parameters worsened, the creatinine worsened, and thereby, if the sprint is applied without in this sprint, so when they have taken 120 or they have taken 140, they have used automated blood pressure instruments. They used with precision. What we take is we take a office blood pressure. Office blood pressure is always 10 or 15 higher. So we cannot, in our office, reduce somebody's pressure below 120. That is the message of this sprint trial. It's an important, very important study. This thing is a HOPE 3 was an important blood pressure trial, and in an intermediate cardiovascular risk group, whether these antihypertensives when the pressures were normal or lower than normal, and then what happens? And they use the thiazide with candicertan combination, and here also something similar data came. There is no significant difference. So you need not give any antihypertensives at 130 or 120 range. You have to give only when it is clearly above 140. That is the message of this HOPE 3 trial. And you don't prevent anything by starting at a lower dose. There is a lot of emphasis on this. All the trials of hypertension, they use very accurate methods of, so accurate blood pressure in the office should be done. So in this accord, this thing, there will stop. The accord is not very important. So here, we said that the goal in all these JNC7 below the 60 years. So try to reduce only below 140 by 90. Now previously there was a concept that if you are a diabetic, you can bring the pressures should be 130 by 80, it should be below 130 by 80. Now this concept has gone, as far as the JNC is concerned, there is no advantage of reducing below 140 by 90, and below the age of 60 and above the age of 60, 150 by 90. Should not bring it below that. And the European Society, in elderly society, and then there is another ASH and International Society, they are recommending that if there is a proteinuria, diabetes, proteinuria, then it is allowed to bring the blood pressure to 130 by 80. So that is the important message. So aim for less than 130 by 80 if proteinuria, albuminuria is present. So one more point is that whether you should take the drugs in the morning or you should take in the evening. And by and large, I think most office-going people would like to take in the evening, and it has been actually proven in this trial, MAPEC trial, is that if you take in the evening, the pressures are better and there is a lower risk of total CV events. But when this Cochrane review means where all the reviews were, all the studies were done, they have not combined thing. It does not change the all-cause mortality or morbidity. So today this question is unanswered, but till that time the answer are available by these two trials. You should take your antihypertensive drugs in the evening. So, as we said, important disease, most important disease, there is nothing more important than hypertension. You should accurately measure the blood pressures. The ABPM is something which should use occasionally. We told about beta blockers. The BP, you should know the figures and don't try to, you cannot keep someone you are treating the pressure at 160. After acquired, you must bring it below 149. That is for sure. The whole problem of all our practitioners of all specialties is that we don't adequately bring the blood pressure by titrating accurately the drug dosages. And till the time the other data comes, evening dose should be taken. Thank you. I actually want to show one case. Can I? I was very fast, and I'm showing that case. Innovation which we did. This is a story of a radiologist practicing here. Youngish, 47. He had some mild hypertension, otherwise okay. On a particular, this Padwa day, he had some, Shitole sir, please excuse me because you heard this yesterday. We had a cardiology meeting where we presented this. He had some uneasiness. He thought it is acidity. Obviously, he took some usual things. He told his wife that, wife said, his wife is also a radiologist. We'll go to the hospital. He says, I am okay, I think if I feel like vomiting, if I vomit, I will feel better. And this has happened, I had taken 1 or 2 pegs yesterday. This is my story, I don't know whether he had taken or not. So he vomited and he started feeling better. But within 5 minutes, he collapsed and on the bed. Then immediately wife rushed, brought him there. And when they came to the porch of the hospital, Dr. Vijay, who is our cardiologist, was, in fact, just his car was behind him. So, because there was a lot of halla gulla and khub gondol hota, he came down and he found that he is having complete cardiac arrest, no respiration, no pulse, fully unconscious, unresponsive. So, Vijay started the external cardiac massage outside in the porch brought inside, and then the massage continued. Then we had defibrillator. This is a VF. He was defibrillated, and this is continued. He was defibrillated about 25-30 times in about 1 hour till the pulse was not returning. So after 10 minutes, we took a decision. The possibilities in this situation were whether to take him to the cath lab and open his artery. But to take him to the cath lab, we knew that he would not make it because it was on the first floor. And to take this, you have got only 3 minutes. If it is uninterrupted cardiac massage, he will have brain will be gone. So after 15 minutes, we decided to give 10 hectoplasm. Now giving this drug is not really a part of this thing. But this is what we had a couple of cases where this is the innovation. And then after about 60 minutes, there was no change. So we decided to shift to the ICU. So we took to the ICU and then we connected then we put him on an intra-aortic balloon pump. He was on ventilator. He was being managed. All the pharmacology was going on, adrenaline, inotropes, soda bicarb, etc. The entire team of about 15 people attending. And the arterial line pressures were there. And then we saw that his pressure started coming from 40, 50, 60. And then he was 100. So once he was at 90, 100, we decided we will take him to the cath lab. We took to the cath lab and this was the ECG I will show. This was the ECG. VF was there. Poor quality because another thing is that we use echocardiography in the casualty. So which revealed the possibility at this stage was either it is a pulmonary embolism or whether it is a myocardial infarct. So by echo told us it is a myocardial infarct. The entry wall was not contracting, so the LED had gone. The EBG obviously showed a very severe acidosis. The ECG showed an entry infarct. This was only taken after even after taking to ICU another 15 minutes. So total time was about 1.5 hours. The pH was 7.1 and he was also hypokalemic, potassium, but I believe that it must not be a correct reading. So we took him in the radial approach, and radial approach is a preferred approach in this. So in this you can see very tight stenosis of the left anterior descending, and then there we decided the patient was stabilizing. He was still unconscious. We decided to wait for 2 hours. 2 hours later we did an angioplasty and we stented that. Cardiology presentation, so please. So we did a left main to the LED stenting. The stent, you can see a undeployed stent. So nowadays the innovation of following this, whenever you have got a stent in the left main, is to do a intravascular ultrasound, which also is a very advanced technique. So we establish a TIMI3 flow. This is intravascular ultrasound. You have to see that the stent is employed correctly by taking ultrasound pictures of that. And then the story begins now. The man is unconscious. Neurologically, we did not know what is happening. So we said, okay, the sedation effect will go. So we waited for 6 hours. still unconscious, pupil sluggishly reacting. So we said, okay, we'll take a call next day morning. Next day morning, unconscious. So we are getting restless. He was stable hemodynamically, blood pressure, everything is stabilized. The whole thing is that he must have damaged his brain, hypoxic injury to the brain. So second day also fully unconscious. So during which another thing which we did was we gave clinically the hypothermia. He was all packed with ice right from beginning. And after 72 hours, he suddenly opened his eyes. And then he said, okay, take this out. He was intubated. So he was, ventilator parameters were all right, so he was extubated. Hey, kutte? The important part of this is my only case where the patient has survived after 1.5 hours of cardiac massage.